All right, let's get right into one of the most notorious diagnostic puzzles in all of medicine. We are talking about dementia with Lewy bodies, or DLB. This disease is basically a clinical chameleon. Early on, it mimics other major neurodegenerative conditions so well that it constantly trips up even experienced clinicians. But to actually solve this puzzle, we need a highly specific clinical detectives toolkit. And that is exactly what we're going to build today. Okay, let's dive into this. DLB is actually the second most common neurodegenerative dementia, right behind Alzheimer's. For decades, it was incredibly frustrating to definitively diagnose in a living patient. You kind of just had to guess based on symptoms. But as this quote highlights, cutting-edge science is totally changing the game. We are finally getting the biomarkers we need to track, classify, and eventually treat this disease with real accuracy. So here's our roadmap for this explainer. 1. Clinical features. 2. Pathophysiology of alpha-synuclein. 3. Diagnostic biomarkers. And 4. Pharmacology and risks. Let's get to it. Section 1. Clinical features of DLB. Catching this disease early really relies on spotting some highly specific clues before it fully overlaps with Alzheimer's and Parkinson's. So the crucial point is what's known as the Rule of 4, which comes from the McKeith Fourth Consensus criteria. We're looking for fluctuating cognition, recurrent visual hallucinations, REM sleep behavior disorder, and spontaneous Parkinsonism. And here is a fascinating distinction. Unlike Alzheimer's, a DLB patient's episodic memory, remembering recent events, is actually pretty well preserved early on. Instead, their brain takes a huge hit in executive, attentional, and visual spatial functions. Let's unpack those first two core features. These patients have these intense, fluctuating periods of profound confusion or severe lethargy that just rapidly resolve. In fact, these fluctuations can be so extreme that the very first time DLB rears its head, it looks like acute delirium, especially if it's triggered by something super minor, like a urinary tract infection. And paired right alongside that, vivid, well-formed, recurrent visual hallucinations. The other two features are REM sleep behavior disorder, or RBD, and Parkinsonism. Okay, so normally when we dream, our skeletal muscles are paralyzed so we don't act out what's happening in our heads. In RBD, that paralysis completely fails. Patients literally enact their dreams, often violently, which can obviously lead to serious injuries in bed. And here's the kicker. This is a prodromal feature. It can show up as an early warning sign years, sometimes a decade, before the dementia hits. Alongside all this, you get spontaneous Parkinsonism, meaning early postural instability, rigidity, and bradykinesia, or really slowed down movements. Now, you might be wondering, wait, if a patient has Parkinsonism and dementia, how is that any different from Parkinson's disease dementia or PDD? Well, it all comes down to a strict one-year rule. If the dementia shows up before or within exactly 1 year of the motor Parkinsonism starting, boom, that's DLB. But if a patient has long-standing Parkinson's disease for years and then develops dementia way down the line, that gets classified as PDD. Section 2. Pathophysiology of alpha-synuclein. So what's actually happening at a microscopic level? The absolute hallmark of this disease is the Lewy body. These are intraneuronal cytoplasmic inclusions. Basically, they are toxic protein clumps physically sitting inside the brain cells. They're made up of misfolded alpha-synuclein aggregates that form these straight neurofilaments. If you look under a microscope, these structures, along with Lewy neurites, will heavily stain for ubiquitin and alpha-synuclein. Because of this specific pathology, DLB is definitively classified as a synucleinopathy. Let's move to and see how this builds across the nervous system, because it's wild. Evidence strongly suggests this misfolded protein spreads kind of like a prion. It often originates completely outside the brain, starting down in the enteric nervous system of the gut or right up in the olfactory bulb. From there, the alpha-synuclein literally spreads neuron to neuron, traveling up the vagus nerve into the brainstem, hitting the locus coeruleus, then the substantia nigra, sweeping through the limbic system until it eventually blankets the entire neocortex. As this toxic wave spreads, it completely decimates specific neurotransmitter highways in the brain, and the clinical symptoms map perfectly onto that destruction. The severe loss of cholinergic projections coming from the basal forebrain, that is what drives those wild cognitive fluctuations and vivid hallucinations. On the flip side, the destruction of dopaminergic projections from the substantia nigra is exactly what's causing that physical Parkinsonism. Section 3. Biomarkers. Unlocking the diagnosis. And this brilliantly illustrates how we can finally, definitively separate DLB from Alzheimer's using modern tech. While Alzheimer's relies heavily on amyloid and tau imaging, we look for very different things in DLB. We're looking at polysomnograms showing REM sleep without atonia, spinal fluid tests checking for alpha-synuclein, and some highly specific deficits on advanced cardiac and brain imaging. Let's actually talk about that spinal fluid test, because it's a real game changer. We now have these revolutionary tests called seed amplification assays, or SAA, and ultrasensitive RTQIC. These assays can take a sample of cerebral spinal fluid and detect absolutely tiny trace amounts of that misfolded alpha-synuclein. This gives us incredible diagnostic specificity that was quite literally impossible just a few years ago. We've also got two powerful imaging techniques in our toolkit. First up, 123I MIBG scintigraphy. This actually looks at the heart. Remember how we said the disease starts in the periphery? Well, MIBG reveals postganglionic sympathetic denervation, essentially nerve damage in the heart itself, which is a classic signature of Lewy body disease, not Alzheimer's. Second, we use a DOT scan. This is a brain SPECT scan that vividly highlights the reduced dopamine transporters in the basal ganglia, proving beyond a doubt that there's a dopaminergic deficit driving the patient's Parkinsonism. Section 4, Pharmacological Management and Risks. So we don't have a cure yet, which means getting symptom management right is absolutely crucial. Because getting it wrong, well, it can be deadly. Consider this very common clinical trap. A patient is brought in suffering from terrifying visual hallucinations. A clinician's first instinct is often to give a standard typical antipsychotic like haloperidol. But what actually happens if you give those standard dopamine-blocking drugs to a patient who has dementia with Lewy bodies? You could literally kill them. Patients with DLB have an extreme, incredibly severe sensitivity to neuroleptics. Think about it. Their dopaminergic system is already decimated. If you give them a typical dopamine-blocking antipsychotic, you can trigger irreversible, severe Parkinsonism, deeply impaired consciousness, and a very real risk of a fatal condition known as neuroleptic malignant syndrome. It is an absolute rule. You must avoid typical antipsychotics in these patients. So what is the safe path forward? We have to target the specific deficits very carefully. For the profound cholinergic deficit that's causing the hallucinations and cognitive fluctuations, we use cholinesterase inhibitors, drugs like rivastigmine or donepezil. For the REM sleep behavior disorder, good old melatonin is actually highly effective. And for the motor Parkinsonism, we walk a very fine tightrope using extremely cautious low-dose levodopa titration. You have to go slow so you don't accidentally worsen their psychosis. But what if the psychosis and hallucinations become totally unmanageable and you absolutely have to intervene pharmacologically? There are very few safe avenues. The FDA-approved path for Parkinson's psychosis, which is often used off-label for DLB, is a drug called pimavanserin. It's unique because it's a serotonin 5-HT2A inverse agonist. Basically, it treats the psychosis without blocking dopamine receptors at all. The only other real alternative is very low-dose clozapine, but that requires intense ongoing blood monitoring because of a dangerous side effect that drops white blood cell counts. Which leaves us with a pretty profound final thought. If this misfolded alpha-synuclein really acts like a prion, starting down in the gut or up in the nose and just slowly marching its way into the brain, could the future of treating DLB actually lie entirely outside the brain? What if the key to stopping this diagnostic chameleon is halting that cascade in the peripheral nerves before it ever touches the central nervous system? It's a completely fascinating frontier in neurology and definitely one to watch. Thanks for hanging out for this explainer, and keep learning.